We switched on it. Yeah, we go. There we go. Well, welcome everybody to the second of the sectoral meetings of the Workers' Inquiry into COVID that Hazards is organising. Just to introduce myself, I'm Doug Russell. I'm one of the members of the Greater Manchester Hazards Centre Management Committee. I used to be USDO's Health and Safety Officer until I retired a year or so ago. And Janet got me roped into chairing this at the Hazards Conference, and that's why I'm chairing these sessions as well. Those who were at the Hazard Conference will know that the one at Hazard Conference was actually a very interesting session. There was quite a large turnout to it, and it was quite late in the evening as a kind of fringe meeting of the conference, but there was a lot of interest in it. And we decided there to follow it up a bit. And so last week we had a look at education, and we had some contributions from NEU, NEU, I can forget which, the National Association of Head Teachers and of Teachers and Women Teachers, and UCU as well. Plus some very good comments from the people who attended. We're obviously a bit thinner on the ground this week, but that's just because there's never a perfect time to organise any of these meetings, I suspect. So what I suggest, because the numbers are small, what would be worth doing is very quickly just running around and letting people introduce themselves and say, possibly while they're here. And then I understand we've got a written submission from the Royal College of Midwives, which Janet will read out, and we'll take a discussion from there. The whole point of these workers' inquiries is that, unlike the formal inquiries that are going in Westminster in Scotland, they're meant to be extremely informal and encourage workers to come across with their own experience of what it was like in the middle of the pandemic, dealing with the lack of information and the lack of guidance and the uncertainty of the whole situation. It's important we keep that open. So if anybody else joins in the course of the discussion, we'll just try and bring them into the discussion as we go along. But perhaps we could start off by people introducing themselves. Janet, do you want to kick off first?
Yes, I'm the coordinator at Greater Manchester Hazards Centre, the chair of the Hazards campaign. I would just say we've got apologies from Unison tonight, and that's because of the national officers, because they're involved in the public inquiry and didn't want to compromise that contribution that they made. And also Raymond Agius has sort of sent me his blog, of which some of it's relevant and some of it's more a general statement. And then I've also got part of a statement from a doctor, and I'm not going to read it all out, but I'll just mention one or two bits from it, because it's not giving me permission to say, we don't want to identify him or to raise it in that way.
Right, that'd be very useful though for the discussion. Hilda, do you want to come in next?
I'm Hilda Palmer. I work at the Greater Manchester Hazards Centre with Janet, and I've been doing lots of work on ventilation and cleaning the air and filtration and prevention of COVID.
You certainly have, and making lots of corioretinol boxes as well to demonstrate how they work. Yeah, Cathy?
Yeah, I'm Cathy Jenkins from Scottish Hazards. I'm the Secretary of Scottish Hazards. I'm also the branch Health and Safety Officer for my trade union branch, which is a not-for-profit branch. And I used to work in the health service, but my experience, I think, of health in the pandemic was social care, really. Because our union organises social care workers, so I can speak a bit about that.
That'd be very helpful, actually. That's an important part of the overall picture. Dawn, do you want to introduce yourself? Dawn?
Hi, it's me. I'm Dawn. I'm a GMB rep. I also sit on the TUC for disabilities. I also work for the NHS. I also sit on the National GMB NHS committee. And because of my disabilities, I was shielded during COVID. But as we know, it was an absolute nightmare. Even when they allowed someone like myself to return to not the job that I originally did. In fact, the role I'm in now is small because I can't go back on the wards. But, we know the NHS itself, it's like they're putting the movie on this week, isn't it? And I'm not so sure whether that's too soon for some people. Because we know that there was things like PPE wasn't available, etc., and all the rest of it.
That's the sort of stuff we need to hear about, I think, but that's very useful to have you here. Thanks. Michelle, do you want to introduce yourself, please?
Yes, hi, I'm Michelle Farrell. I'm from Thompson Solicitors in Manchester, and I'm the principal lawyer of the disease team and have an experience of members who've approached us regarding potential personal injury claims for COVID exposure.
Very much. I should add that Thompsons have said they're going to be providing somebody at all of these sessions, I think, haven't they, Janet? So she's very welcome, because it's a very difficult area, and it's important to have somebody who can speak with some authority on it, I think, on that. And Jonathan, finally.
Thanks, Doug. Yeah, I'm Jonathan Fluxman. I'm a retired GP. I'm COVID lead for Doctors Unite, also in the COVID pledge campaign. I'm particularly pleased to see you here, Michelle. I've also been working with Long COVID Doctors for Action, and you may have seen the media a couple of weeks ago now. They've just gone public with a group claim that they're going to make against NHS employers for injury and losses due to COVID infection. And it'd be great to have a conversation about the legal aspect. And flowing on from that, part of the press publicity for that were a number of statements, anonymous, from the doctors about how COVID affected them. And as you were making the introductions, Doug, I was thinking I will ask Dr. Kelly Fernley, who's chair, if we could incorporate that material into the COVID workers inquiry.
That would be good, thank you.
I think it'd be a good addition, and also help bring doctors into contact with other workers, which has been a process underway for a while now with the strikes and everything, and it'd be good to work all together. That group claim, I should add, is open to all healthcare workers, not only doctors, ancillary workers, porters, cleaners, nurses, physios, and so on. Thanks.
Thank you. Okay, so it's a fairly select group. It's still quite a broad spectrum of backgrounds, which is going to be very helpful in the discussion, I think. Janet, should we start off with the statements that you have got, with the RCM one first, I suppose, and then we'll go through the doctors' ones?
Yeah, okay. So the COVID-19 pandemic presented particular challenges for maternity services, given the limited scope for delaying or rationing care and treatment, and the additional pressure on the services due to the inclusion by the government of pregnant women in the vulnerable group category resulted in considerable anxiety for many pregnant women, new mothers and their families.
Sorry, Dawn?
For the RCM, the initial challenge was how to support maternity services, our members and women and families through what was rapidly evolving and extremely stressful time. Our main aims and objectives were to communicate to government and other decision makers the unique challenges faced by maternity services, to reassure women and families that midwives and MSWs would continue to provide safe and high quality care despite the pressures and constraints that services were operating under. And 3, to ensure that midwives and MSWs' rights at work were protected and that their health and well-being was prioritised. Within the context of these objectives, we identified a number of early priorities, including ensuring that maternity service staff were ring-fenced from being redeployed to other services. From the outset of the pandemic, the RCM and the Royal College of Obstetricians and Gynecologists were clear that it was vital to maintain all aspects of a safe maternity service and to designate maternity care as an essential service. This was a particularly urgent issue due to the way in which the pandemic exposed and exacerbated already serious staffing shortages in the maternity services, with a number of midwives and MSWs absent due to sickness or self-isolation increasingly significantly, with some services in London operating up to 40% below their staffing establishments. Our arguments for the ring fencing of maternity services staff was generally accepted, and this quickly ceased to be an issue of concern. Supporting the continued operation of maternity services, the challenge of trying to maintain the services whilst operating with severe staffing shortages led many service providers to make the difficult decision to rationalise care. This usually took the form of suspending home birth services, temporarily closing birth centres, concentrating interpartum care with obstetric units and providing some antenatal and postnatal consultations online or by telephone. We recognise that directors and heads of midwifery services were having to make decisions based on being able to provide the safest possible care for women and babies, depending on the available staffing levels and local circumstances. We also wanted to support maternity services to get the message out to women and families that despite the reduced care options available, maternity services were still open and that women should keep their routine appointments so that services could maximise their safety. This was in response to early indications that some pregnant women were reluctant to attend hospital appointments due to the anxieties about COVID-19 and may therefore have been missing consultations or not seeking advice. While broadly supportive of measures to limit the presence of women's partners when women were attending for scans and routine appointments, we did encourage services to allow the presence of partners during labour, birth and the period immediately after the birth. Maternity services were able to accommodate this in all but a very extremely limited number of circumstances. Keeping staff safe and well, our members were understandably very anxious about the risks of exposure of COVID-19, about the availability of PPE and testing, and for community-based midwives, the risks involved in entering women's homes. A survey of RCM members in April 2020 found that 1/3 of respondents reported experiencing shortage of PPE. In response to these concerns from members, we worked with other health trade unions and professional bodies to hold the government and employers to account for providing appropriate and adequate protections for our members working in healthcare, on ensuring that services were properly resourced and equipped to protect staff, and on ensuring that new staff or those returning to services were properly supported through training and supervision. The government advice placing pregnant women in vulnerable persons category was announced in March 2020 without any prior consultation with the RCM and without any supporting evidence, particularly in respect to the designation of the 28th week of pregnancy as determining the precise level of risk for pregnant women. The effect of this announcement was to leave many pregnant women feeling anxious and vulnerable about their employment situation, particularly if they're in the frontline workers. Despite this, the NHS was slow to provide advice and support about the implications for pregnant workers, and in the absence of guidance from the employers, the RCM worked at pace with colleagues at the RCOG to provide pregnant women with guidance which made clear the obligations on employers to protect their health and safety, including undertaking work-based risk assessments and, if necessary, offering suitable alternative work or suspending staff on full pay. Despite numerous requests to get the government to publish the guidance, given that it was government policy that necessitated the guidance in the first place, it was only in October 2020 that DHSC finally agreed to do so, after the Department for Business, Energy and Industrial Strategy had repeatedly refused our request to publish. The government withdrew this advice in April 2022 and moved that the RCM opposed on the grounds that it undermined the legal regulations and requirements in place to manage the risk of COVID-19 in the workplace for pregnant women. Had the RCM and RCOG received prior notification from government, we could have worked with them to ensure that the guidance and advice was in place before any announcement was made. Regrettably, the government missed that opportunity to provide clear and timely information to pregnant women, which could have prevented unnecessary stress and uncertainty. This was an abdication on the part of government, requiring RCM and RCOG to step in to undertake a role outside our usual responsibilities. We also responded to emerging evidence that Black, Asian and minority ethnic women were in higher risk of experiencing severe COVID symptoms, and that allied to general anxieties about exposure to COVID-19. This was resulting in missed appointments and reluctance to attend hospital. Accordingly, we launched a targeted campaign to raise awareness and reassure BAME pregnant women of the availability and safety of maternity services. We developed guidance for midwives and MSWs to ensure that they were aware of the increased risks for BAME women and could have informed and reassuring discussions with them. In June 2020, the Chief Medical Officer and National Clinical Director for Maternity and Women's Health outlined a series of actions to address disparities experienced by BAME women, including a lower threshold for admission and referral to BAME women and their babies, better and more tailored communications, additional nutritional support, and the collation of more accurate data on ethnicity. While we supported these initiatives, we argued for further and more extensive action and publicly called for an explicit target for elimination of racial disparities in rates of maternal mortality. We were also concerned about how the pandemic was exacerbating inequalities experienced by BAME staff. During the first wave of the pandemic, 60% of healthcare workers who died from COVID-19 were from BAME backgrounds. We raised awareness amongst our members and the need to be risk assessed at work, and we called for employers to act on the evidence. With other NHS trade unions, and produced a set of principles on health and safety risk assessments. We encouraged our local representatives to develop local policies and procedures and produce wraparound guidance to aid understanding among our members. Issues during the second wave of the pandemic, as the service emerged from the initial phase of the pandemic, the balance that maternity services sought to achieve between openness and safety came under increasing pressure. In the absence of national lockdown and with different parts of the country subject to different restrictions and regulations, we recognised that maternity services required a more nuanced and localised approach. Rather than one size fits all response to the first wave of the pandemic, according to the RCN and RCOG, formulated a set of service planning principles based on maintaining day assessment and triage services, along with active encouragement. Accordingly, the RCM and RCOG formulated a set of service planning principles based on maintaining day assessment and triage services, along with active encouragement to women and to attend appointments, maintaining options for place of birth subject to local staffing capacity, and offering a full schedule of antenatal and postnatal care. We reviewed and updated our COVID guidance, reconvened the working groups, and set up during the first wave and renewed our collaborations with the RCOG, the TUC, and other health unions and professional bodies, and with user groups such as Maternity Action. We repeated our call for ring fencing of maternity staff, and this was once again heeded. In the summer and autumn of 2020, maternity services came under increasing pressure from groups representing maternity service users, sections of media, and some politicians to effectively end visiting restrictions for media services. Sometimes these calls were based on misleading and inaccurate reports that women were being denied support during labour and birth. Feedback from our members also indicated that the way in which this issue was covered was contributing to an increase in abuse that midwives and MSWs were receiving from pregnant women, their partners and families. Whilst we recognise that visitor restrictions were far from ideal, they were designed to maximise the safety of women, the partners, the families and maternity staff. They also had to be seen in context of the reality of many maternity services went into the pandemic with capacity at near or very near breaking point. The government could have acted to clarify visiting arrangements to reassure women and families about the support that they're receiving. At the beginning of August 2020, a framework agreement to support safe reintroduction of partners to attend appointments and scans had been developed by the RCM, RCOG and Society and College of Radiographers. Unfortunately, it took NHS England a further month for it to agree to publish it, largely failed to take ownership of it. Had NHSE acted in a timelier way, there's a very likelihood that visiting would have become less of an issue, especially at that point when it was becoming clear that the country was facing the second wave of the pandemic. The way in which this issue was handled and communicated was indicative of pressure that NHS services were under to return to normal. Our concern was that the understandable desire for restoration of maternity services needed to be weighed against a considerable physical and mental toll that the pandemic took on the NHS workforce. While midwives and MSWs remained determined to support the women in their care, their health and well-being was being depleted. Staffing shortages had been exacerbated by self-isolation protocols, and the pressure to return to work was as normal was causing real anxiety. We were disappointed that the NHS was again slow to support their staff, and that at a higher political level, there appeared to be little attempt to understand and mitigate the pressures that frontline staff were under. In the continued absence of guidance from government or NHS England, maternity services faced further pressure to remove visiting restrictions. Despite raising COVID rates and the fact that maternity waiting areas were shared with other services, and challenging in maintaining social distancing in some antenatal and postnatal wards. In November 2020, the RCM and RCOG reiterated the need to reduce the number of people coming into maternity departments in order to protect women, babies and families, and maternity staff at a time when community infection rates were rising across England and when increasing numbers of midwives and MSWs were either testing positive or needing to isolate. And then just issues during the third wave. In April 2021, NHS England issued new guidance for NHS trusts to enable pregnant women to have a partner, family or friends with them at all stages of maternity care, whilst ensuring safety for maternity service users and staff alike. The guidance was welcomed by the RCM and RCOG as striking the right balance between enabling women to have the support they needed while ensuring that safety of maternity services staff. Along with RCOG, we did, however, continue to raise concerns about rising infection rates amongst pregnant women due to the easing of restrictions on NHS services, continuing high rates of prevalence of COVID-19 in the community and vaccine hesitancy amongst some pregnant women. And at the same time, as urging women who are pregnant or considering pregnancy to get vaccinated as soon as possible, we continued to advocate the continuation of social distancing measures and for pregnant workers to follow occupational health guidance. That's it. You're on mute, Doug.
Right. Obviously, it's a very specific part of the health service because it was the College of the Royal College of Midwives obviously deals with maternity provision as their main area. But I think it's quite interesting, some themes coming out of that we've heard from other sectors in the health service as well, around things like the PPE. Particularly strong for me is the lack of government consultation and the lack of government leadership in all this sort of stuff. For other workplaces outside of the health service, the Royal College guidance was actually very useful when we were trying to figure out how to deal with members who were pregnant, certainly in the retail sector where I was working at the time. And it was very good guidance, but it's disappointing to hear that was all stuff that was done by the RCM and RCOG themselves without much government input and without much government support in all of that as well. Anybody else got any other comments specifically on what we've just heard from the RCM? And others will suggest a way we might move forward with this. Kathy?
Yeah, I just wanted to say that I wasn't involved in the casework that Scottish Hazards did during COVID, but I was involved in reporting that to the Scottish Government, and we had at least three, well, we dealt with about 500 cases, but there were a number of pregnant women that were dealt with by the caseworkers, and they were pretty horrible situations where women who were pregnant and had underlying health conditions. One was a Black minority ethnic woman, and another one had underlying health conditions, and their employers were just basically saying, you have to come to work, hadn't done proper risk assessments. And the third woman was, she worked in a lab, and she was actually found out that she was working with she was working with tetragenic materials, is that the right word? And told her, so not even to do with COVID, but to do with normal risks, and her employer just kept telling her she had to work. And we managed, I believe the caseworkers managed to help all three women that I know of. There may have been more. And just to reiterate what was said in that evidence, the Maternity Alliance was extremely helpful in giving advice about that. And I think the caseworkers did manage to get at least one of the women on to full pay at home,
Yeah, suspension of full pay.
Yeah.
Yeah.
So I just thought I'd report that because it's very much chimes with what she was saying.
Jonathan?
You're on mute.
Mute.
Sorry. As you say, Doug, a very interesting and well-written report, and highlighting many of the themes that are familiar to us now. I mean, the fact that everybody had to write their own guidance for their own members in their own sectors. The government was just AWOL. And I remember, Doctors in Unite, we were also doing the same sort of thing for our members and talking to other people, and what guidance came out always minimized risk, always, erred on the side of fewer protections, and I say protections, deliberately rather than restrictions, which of course protections were called in order to create the whole business that this was a gross imposition on our freedoms and was, basically unnecessary. The visiting restrictions, it was really interesting to hear their perspective on that, in maternity services where it's so important to have partners and family around. And again, had we had a rational, sane policy which was centered on airborne transmission from the get-go, and now we know from the inquiry, we know full well that they were definitely aware that this thing was airborne from day one, and they hid it and they buried it. But had we had an airborne-centered policy of stopping transmission, partners could have come in wearing FFP3 masks, could have had well-ventilated wards and clinics, and that total isolation and separation and could have all been avoided. Of course, risk would never have been zero, but that could have been discussed with women in their pregnancy, and they could have made the choice. And what would we end up doing? These incredibly heavy-handed, no visiting whatsoever responses, which left women traumatized and alone, and many of them got sick because even when they were alone, the proper protections were not in place, and they got sick, and some pregnant women died. We know that, and they lost their babies as well. So the same old issues over and over again. And then just lastly, again, I was pleased to hear mention of Black and Asian workers. We in Doctors United wrote quite a bit about this, and I was thinking that we'd happily make that evidence available to this part of the workers' inquiry, because it does set out all the myths of. I'm sure you remember when the figures came out that, oh, it's genetic and it's lack of vitamin D and it's lifestyle factors. And no, it wasn't. Black and Asian healthcare workers were getting sicker or getting sick more frequently because they were exposed more frequently.
The jobs they did, yeah.
And it was institutionalized racism all over again. Thanks.
Yeah, that was one of the other themes I was going to pick up on, that I think is much wider application than just with the RCM themselves. So it was a very strong one in other areas. Dawn, you've got your hand up?
Yeah, I mean, you've touched on, I believe so far that not all the facts are completely, it's the same with disability, isn't it? And the subject of COVID and long COVID, which is an ongoing battle. I know as reps, we're still, 1 minute they put things in place for staff with long COVID, and then when the government moved the goalposts, it's like, we know there's people now, staff members as well as members of the public, suffering with long COVID. We know they are. And, it's making sure that they don't become part of the triggers, because it's still an unknown anomaly, just the wide-ranging effects of COVID. I know I've had it twice. And I know it's altered my look. And then, the studies around race as well. Again, I know we're still battling along with the disability and race to get all the facts published, because they're not so forthcoming with all the facts regarding that around race. You've highlighted a classic one there, that it was all these excuses made, but let's face it, a lot of big Black and Asian and minorities often either featured heavily on the front line, or they were the doctors and nurses themselves, sticking to doctors, and that's why we lost so many of them. As I worked predominantly with older adults, one of the things I noticed with my team, though, even when I was shielding, and then I was allowed to come and join the older adults community mental health team and went that way, and then dementia support services, was the PPE issue. And the fact, as we all know, that hospitals said people had been, screened for COVID, and they hadn't. We would get it. The only time COVID came to the older adult mental health ward in my area was when the hospitals discharged to us. Other than that, it hadn't got, and it's the same with the nursing homes. the only time it came was when people were discharged, and it's all our hospitals saying the screen because of the pressure. No, they didn't, but we know the directors would. Things were said behind closed doors, and this is how it spread. And we know the losses we got in the nursing homes, residential care homes, and some staff locking themselves in with the residents rather than, you know, taking it home to the families, and also because you didn't want to lead the poor elderly people or people learning disabilities on their own because they're frightened. They don't know what's happening to them.
Yeah.
And there's a whole ream of things and other factors. I mean, one of our nurses, he went on Panorama. You mentioned FFP3s, and he went and showed the presenter that the masks that they had on their unit were all out of date. You know, it's all these things that, apart from 1 minute they said they hadn't got the PPE. I believe that there was some stock somewhere in the country, and the fact that they were ill prepared. Then you got that report years ago where the government has supposedly written a report on how to manage a pandemic, and then when it comes to, it's not fit for purpose. There's a whole ream of backlash over this that really needs looking at, doesn't it?
Yeah, some very important stuff in there. Yeah, there are a number of strands we can go down and look a bit further at, I think, in a bit more detail. But Kathy, do you want to come in? You said that you were dealing a lot more with the care side of stuff as well during the actual pandemic itself. Is there any more comments you want to add about any of the things we've heard from Dawn and from Jonathan, particularly about what was going on in the social care? And
yeah, I mean, I think people know probably what I would say, but it was just because we unionize people working in social care. We were trying to, and it wasn't so much hazards casework, it was more me because I'm in that union branch and was the health and safety officer. But what we were finding was that all the I think it's probably not fair to say the problems that were highlighted in the health service were even worse in social care. So, you know, the lack of PPE, it wasn't even so much that there was a lack of it. They just were being told they weren't going to get it, you know, and then social care. And then eventually when it was agreed that they should get PPE, it was very limited. It was like possibly plastic aprons and the surgical masks. Yeah. And even then, the social care employers were having to pay for them. So we were told that the NHS would provide them, but actually then they were charged for them, and therefore the social care providers were in a difficult position of how many do we buy, where do we get them and stuff. And then another issue was that because of the issue, I mean, Jonathan said this, because they were denying that it was aerosol spread, the guidance was that you only had to have FFP3 if, you know, if it was an aerosol generating procedure. Well, we had social care workers who were working with people with epilepsy who were having seizures, and were doing personal care, and we went straight to the Scottish government, we went to the NHS, and they wouldn't say that that was an aerosol spreading procedure. So we couldn't get proper protection, even in situations where it was very clear, even without saying that it was generally aerosol spread, should have been covered. So that was an issue. There were big issues with when testing came in, it was being very difficult for social care workers to get the tests. At the beginning. I mean, obviously they did eventually, but they were told that health and social care workers would be prioritized. But the employers were telling us, as well as our members, that they were finding it very difficult to access the tests, and that was the same for vaccinations when they came in. It was social care workers were not getting the priority that they were being told they should get, because by that time everybody knew they were highly at risk. And the other thing, I mean, there's loads of things, but the other thing I would say is that, well, two things. The we mostly deal with home care workers, not care home workers. So it was people going into people's homes. And there was a lot of confusion about should people be going into their homes or not. Employers were saying, well, you should, but, and, take precautions. Well, there were no precautions. And then when in Scotland, when it was said that, people should not go into each other's homes, that was the law actually for a while. Care workers were saying, well, they were going into the homes of people they were looking after, and there were other people there, and they didn't know what to do, and some employers did back them up and say, no, don't go in. Others didn't. It was a bit mixed bag. So that was an issue. And the other issue was, all the stuff about how to dispose of PPE safely, and all the regulations about that. Well, people going into people's homes had nothing, and some of our care workers were actually taking plastic bags of PPE home on the bus because they didn't want to leave it in the person's home. There was no way of disposing of, so those were some of the issues.
Very important stuff in there. That one about what to do with people going to homes, that chimes with the community midwives and also community nursing care as well. There's somebody.
It must have been exactly the same. Yeah,
exactly the same issue, and they do need to go into homes because that's the only way they can care for the patients they're looking after. Janet, I don't want to lose the stuff from Raymond Adjuce and the stuff you got from the anonymous doctor as well. But are there any? I know that Raymond, for example, in the BMA was very much involved with the issues around PPE and what should be appropriate PPE in those sort of situations, and very much headed up the BMA's campaign around airborne infection risk. Is there anything from what he's said or anything from what the doctor has said that you think ties in with the sorts of themes we've been discussing so far? You're on mute.
Raymond sent his contribution that is made for the inquiry, I think, on behalf of the BMA. And he talks about loads of shortcomings that they had in occupational health, and he says occupational medicine as a discipline needs to be better prepared, and hence to assert its responsibility towards high standards of workers' health protection in the future. But he talks in here about the changes that were made to the definitions, I think, of what COVID was, and also about preventing transmission in the workplace setting. So he says, contrary to beliefs before the pandemic and common with some other Western countries, the national UK pandemic control systems were very disappointing in the performance when compared to prior expectations in 2019. However, this did not happen fundamentally because the basic principles of public or occupational health, as traditionally taught by and to practitioners in this area, were flawed. Rather, the failures arose firstly because of the prior and underinvestment. Secondly, public as well as occupational health principles were ignored or overridden. And instead of fatalism, the country needed a determination to find ways and means to practice traditional principles of public health and occupational hygiene, especially by using national resources to provide and mandate clean air in workplaces elsewhere, and together with specific measures to protect workers. The ethos of occupational health protection in the UK is to ensure health at work in the words of the law as far as reasonably practicable. This means reducing the risk of ill health, whether or not the outcomes are likely fatal. Yet on the offset of the pandemic, a decision ostensibly determined by infectious disease and public health experts considered the case fatality ratio of COVID-19 not bad enough to offer RP to the vast majority of COVID-exposed healthcare workers. Such an outlook on work and protection is alien to the good practice of occupational health. It would be tantamount to denying eye protection to welders or hearing protection to safety boots to quarry workers on the ground of blindness, deafness and crushed feet are not deemed fatal injuries. Another analogy might be occupational asthma. How would society react if workers exposed to asthmagens were such as flour or were denied protection because yes, the disease may be fatal sometimes, but not usually. So occupational health principles need to be reasserted as a robust response to the dangerous combination of death and ill health of workers caused by COVID.
And that whole thing about it was clear from the evidence we had all the way through this inquiry that occupational health was just missing because HSE held its hands up and said it's all public health that's got to deal with this and not anything from the anonymous doctor statement that you think is worth actually stating.
I would just say that he said he knows of at least 3 members of staff who died of COVID during the pandemic. But there is evidence that reader reporting process were not taken seriously.
It's another theme, yeah.
Yeah, and inaccuracies of recording staff absences due to COVID infections. There was massive amounts of people off sick, but it wasn't reported or recorded anywhere. And no suitable sufficient assessment of the risks in place. And then there's no mention about the presenteeism. So people going into work, continue to work when they were ill, just to make sure that they had a service to provide. So there's all sorts of things that he raises, in the way that they were treated, and the need, well, I mean, a lot of it's about enforcement and about, expectations of the service, but not proper risk control, really, I think.
Yeah, and that point about presenteeism and going into work when you're infectious is actually still a problem, isn't it? Particularly with the recent this winter when we had the rise in the new variant of COVID. And as the RCM said at the very beginning, there's already an issue with under-resourcing anyway, and understaffing in the health service, which has been made worse by people being off sick and other people going off sick because people who are sick drag themselves into work rather than put their workmates under pressure. It's a horrendous situation. Michelle, you've been very, very, very patient all the way through this and listened quietly to what's all been going on. Obviously, your job is to try and help people who are the victims of all of this to get any access to some form of justice if they got a chance of making personal injury claims under the current law. Do you want to say anything about how you're getting on with those sort of cases at the moment?
Yeah, unfortunately, it's not really very positive. Obviously, the law doesn't change because this is a pandemic. The law is the law. And with COVID, because of the way that it spreads and it's transmitted, it's difficult to identify the source of where it's come from. Not so much, obviously, when we were in lockdown and people weren't in as much contact, although obviously people in healthcare settings were still having that type of regular contact with individuals who were poorly. But also, as time's gone on and we're open, and as you say, people going into work, I think I've got a sniffle, it's not, it's COVID, and, they don't realise that till sometime later, and obviously other people are infected. So source of infection is a big hurdle to get over, but it is something that has to be considered because we need to identify that source and also make sure that the incubation period that is 3 to 7 days-ish. I know that there's varying views on this as to whether it's up to 14, but the experts that we spoke to said that it was 3 to 7 was probably a reasonable period. So identify the source, when did they come in contact with them, and was it in that incubation period? Obviously, was that source in work as well? People using public transport to and from work, again, could pick up infection that way. Again, lockdown, it was slightly easier, not so much now where, we're back to normal, if you like. From that also, people don't always have symptoms initially. They can test and not have the symptoms, so we can't then identify source, incubation period. So that's a hurdle as well. Once we can get over that, then you're looking at what the guidance was in place. Now, I fully appreciate and I'm very sympathetic to the fact that, particularly in the NHS, it changed very quickly, because one week it could be guidance saying you must do this, that and the other, and next week Public Health England was saying you need to do something else. But the law will be bound.
There was different guidance in different parts of the country, as was pointed out as well.
Yeah. So, so again, the law is based on what was in place at that time. If the trust or the employer at care homes has followed that, then you're pretty difficult to get over that hurdle, unfortunately. PPE, I know, was an issue, but a lot of it was that surgical masks were sufficient unless they were doing, they needed a airborne sort of we were saying before about that, and the better mask that was to be provided. Again, it's difficult, isn't it? Because you could have a patient who's, you know, not been tested for COVID, not showing symptoms, but actually are COVID positive, and somebody's not even wearing a mask. You know, it's an impossible. You know, it's impossible to be able to identify the source. So, unfortunately, it isn't easy to proceed with the cases, and we have had a range, as I was saying prior to the meeting starting, from, you know, people who've had very limited symptoms wanting to make a claim, but we've also had the sad end of that where there's been fatals, particularly more at the beginning of lockdown. We did unfortunately receive quite a few cases, and again, you mentioned about RIDDOR. We've had issues with, you know, not completing RIDDORs, individuals having to really push to get it reported. It not
Wasn't
being
held by the
noted.
HSE guidance on RIDDOR.
Well, the HSE, some of the investigations they did were really lacking to help these individuals. And I know I spoke to a representative from the HSE, and she just said they were overwhelmed with the number of notifications that they'd received, and, you know, it was just trying to do the basics, but obviously that doesn't help an individual who's lost a loved one whilst just going to work to do their job. But yeah, a lot of the things you're saying are things that we've seen as we've got these cases in, but unfortunately the law isn't particularly helpful in trying to pursue these cases.
Yeah, thank you for that. Jonathan, you've got your hand up.
Yeah, thanks. It was very interesting, Michelle. I've been quite involved with Long COVID Doctors for Action and their legal case, and certainly some of the issues that you've raised, you know, we've discussed that with the lawyers, and I mean, they feel that, you know, they're doing a big group claim now, and probably be hundreds of claimants. That some of those grounds are not as difficult in their assessment. And I'm just wondering, I don't, forgive me, I don't know how lawyers work with each other. When you sort of, if you're representing different clients, but on the same issue, like a personal injury claim for COVID, do you at all collaborate with each other in terms of discussing with other firms the sort of evidence base and the sort of, you know, the burden of proof that you have to reach, and share strategies to any extent?
Well, what we
Don't mind me
did was,
putting on the spot.
no, it's okay. Well, I thought you were going to say it, because obviously I'd be interested to know what their approach was actually in relation to the cases, because we had a period when we, obviously from the March 20, where we were getting cases in, but we were waiting to sort of see how things sort of managed out. But we actually had advice from an occupational hygienist, a specialist in PPE, and a chest consultant. And they did a lot of work for us in relation to looking into some of the cases. We picked a couple of lead cases to get off the ground. And then we had a now QC look at the papers, look at those cases, and the view was that they wouldn't be able to pursue them because of the points that I've raised. I mean, the law doesn't look at hindsight, so to judge it now, I mean, obviously it's pretty clear that a lot of the stuff that was being said about what you should be doing in the workplace and social distancing and the PPE, etc., was basic rubbish. But and there was no sort of genuine there'd not been any sort of investigation behind that into, you know, was that the correct guidance? All very rushed, all very just implement it. But that's how we looked at it. And we, as I say, we had a couple of lead cases that we made claims on, which we ran to a certain extent, got some evidence, but the experts were of the view that they would be difficult.
Kathy, you've got your hand up.
It wasn't really specifically on the personal injury stuff. It was relating to what we spoke about slightly before, although it relates to what you're saying, Michelle, about PPE and about, you know, the issue of people, but it was about the issue of people going into work, presenteeism, whatever. Certainly in the social care sector, I don't know whether it's the majority, but a very high percentage don't have any sick pay.
Yeah.
So that became a very big issue, because the Scottish Government, to give it its due, did put together a fund that you could apply for to get a payment if you had to self-isolate. But it was somewhat flawed because it went through the employer. And some employers weren't great about passing it on. So when we're talking, because we're core participants in the public inquiry up here, we're saying that, you know, if this happens again, when it happens again, that, you know, that such a scheme should go straight through the worker rather than through the employer. But sick pay was a big issue for social care workers.
Very good point, actually, and for agency working staff as well, particularly. Janet.
Yeah, I just want to come back on the point that Michelle has made about the use of experts, you know, that you used on those to define those issues. Because what we've been finding, you know, in all the conversations that we have around all those issues, are different experts are saying different things for all sorts of reasons, you know. And so I suppose my question would be is how did you determine those particular experts? And, you know, if we knew who they were, would we say there's somebody else who'd put a different point of view there, you know, and
Yeah,
is that
I mean,
to challenge really, like, you know?
But sort of on a general view, in any personal injury case, you can pick an expert to say one thing, and you can go and see another expert with the same qualification, and they'd say something else. I mean, that's why, you know, claimant solicitors use certain expert and defendant solicitors use certain experts, because they know what they're going to say. I wasn't involved in it, but it was done by the head of disease, and we looked around. I know that they did look around at various experts who could help us, because there's limited experts in sort of the field of PPE as such. You've got your general sort of occupational hygienist types. We wanted someone who's a bit more specialised, and the expert that we used is for the medical side of it was quite highly regarded. So again, you know, it is differing views, and there's also, like I say, a little bit of hindsight as well. But I know that the barrister took an overall view and advised as well on generally sort of applying the general principles that we'd have to overcome to succeed. So it was a mix of different aspects, not just the expert, but we did, as I say, instruct experts to look into it and guide us in relation to their knowledge.
We're running out of time here, but I don't want to miss out on Hilda and Dawn because you've got your hands up as well. So do we go to Hilda first? Because I suspect you've got something on this same theme about the experts.
Yes, Janet got in there before me. I think that had concerned me, because I have had conversations with fairly high level PI people in solicitors' profession, including in Thompson's, and it did really very much disturb me that the sort of experts that you were using, apart from perhaps the occupational hygienists on PPE and things like that, who would be appropriate, that some of the other people that you were using were not necessarily the best on their own, and that you really needed to be talking to indoor air quality and aerosol specialists in terms of, you know, the whole issue around airborne transmission and ventilation and filtration, measuring ventilation with CO2 monitors, and developing, understanding a case. And I was really quite disturbed to hear some solicitors still talking about aerosol generating procedures, which, as we know, and you've said, Michelle, earlier, that a lot of it was complete and utter nonsense. And that does disturb me, because in terms of developing and assessing the evidence base and what chances you've got of going forward on PI cases, which I understand and you explained very, very eloquently and clearly how difficult
but that's
they
also
are.
that's also where they've got to take account of what the guidance was at the time that they were following.
Yes,
and the guidance was
absolutely.
So many GPs that you have to
and
provide.
that's why
more
I wanted to
protection.
come
So
on
that's
to the last bit of it, really, which is what I really wanted to say was following on from that is, I think in terms of legal stuff, what we perhaps really wanted to know and be clear about is how can or how possible is it to make legal challenges to the actual guidance that was given at the time, and how wrong that was by, you know, public health, by HSE not giving its proper advice, by the NHS, by the infection prevention and control sort of people. How possible is it to challenge those sort of procedures which provided the guidance on which employers were depending, and then failing to correct people? And it's not a PI case as such, but it's
No,
actually
I understand.
challenging.
Yeah, just the general guidance side. But that was something that was looked at as to whether they could bring an action. And And from memory, I think what was said was that the likely argument to come back on that is, well, they were just acting upon what was known at that time, and you sort of then whether that's sufficient. Now, as far as I know, I'd have to check with Dan, who's head of disease, but as far as I know, I'm not sure that's gone much further. But as I say, I'm not directly involved, but I do know it was something that was initially looked at. A couple of the unions wanted to challenge the guidance that was put out, how it was put out, and particularly what it was based on, really, and what they should have been taking it maybe a little bit more serious.
Yeah,
Okay,
it's a
thanks.
very complicated area, that. Very quickly, could we just get Dawn's comment, and then I'm afraid we're going to have to wind up because we've run a bit over. Dawn, what was it
I
you
was
wanted
going
to
to
say?
say, when you think of what's come out now
Yeah,
from the experts, that I mean, the actual scientists saying, to be honest, that the PM hadn't got a clue, and that there were times that they themselves were arguing amongst themselves because nobody was really listening to them. Is it any wonder that solicitors and people are in a quandary now, because it's all coming to light? Because at the time, nobody, they're saying one thing to sort of keep us all, well, I suppose, trying to keep everyone going to some extent, and the reality was different behind closed doors, wasn't it?
yeah, very much so. I'm afraid the hypocrisy of central government was quite astonishing all the way through that process, and there's more for that to come out, I think, in the other inquiries that are going on. Well, thank you very much for your time. We've actually run over by about 5 minutes, but it was very interesting discussion, and I thought it was important to get some of that stuff down. The next one of these, Janet, is March the
14th.
and that's on transport, is it?
I think it's the transport one.
Yeah, which is again another sector which is very badly affected because they were essential workers. But it also raises the interesting point that the workers we've been talking about today and last week had to use public transport to get into work as well, and that was another area where they were exposed to risk, and one which unfortunately wasn't one. They can claim against their employers' insurers if that's where they got it. So that's another problem we've got to discuss next time, I think. Thanks very much for your time, and this has all been recorded, so it'll all be there available in the future for other people to feed in as well. So